Okay. Well, welcome everyone. Thank you so much for joining us today. We're going to talk about the head, eyes, ears, nose, and throat. My name is Hiva and I'm with Archer Review. And in this webinar, we're going to go over all the do's and don'ts. We're going to talk about what you need to know for your boards, what you need to know for clinical practice. We're going to keep it light and fun because I know you know this and I know you're going to do a great job both on your boards and in your clinical setting. So what I want you to do is get out your chat box and go ahead and put in your questions as we're going along and put in your answers as I ask you questions because I know you know it and it's going to be a lot of fun. So we're going to keep it light and engaging today. So let's get started. So first, we're going to start with the eyes. Best piece of advice I got going into clinical practice, and I still use it today, is know your anatomy. So know the anatomy of the outside of the eye, know the anatomy of the inside of the eye. It's going to really help you identify when you're seeing something abnormal in the clinical setting, right? So you don't have to know everything about the eye. You don't have to know all the diseases. You don't have to be able to diagnose and treat all the diseases. That's what specialists are for, right? But you do need to know how to practice safely. So what is something that you're able to treat in that outpatient setting in primary care? And what is something that you're going to emergently send over to ophthalmology or the emergency room if you don't have an ophthalmologist on hand? So, and that's what the board's going to ask, and that's what they want to know. Are you going to be safe in practice? Are you going to know what's normal, what's abnormal, how to treat things that you can handle in primary care, and how to refer out? So that's what we're going to go over today. So know your anatomy. It's going to help you a lot. When you first enter clinical practice, you will feel really overwhelmed, right? Patients are going to come in, they're going to have their complaints, and you're going to be like, where do I start? History is going to be really important, and your good old-fashioned old cart is a really good way to start the conversation with your patients. So they're going to come in and tell you, oh, my eye hurts, or my eye's been goopy. And so just go through a systematic old cart just to get a little bit more information from your patient. That's going to really help you with your differential diagnoses. And then for eyes, I really want you to go into past ocular history with your patients. So do they wear corrective lenses? Do they wear contact lenses? Have they had eye procedures done in the past? That's going to be really important. Have they had laser procedures, repairs? Have they had trauma or frequent infections to the eye? Have they had any retinal disease? Remember, the general medical problems that we see, diabetes, hypertension, heart disease, thyroid, inflammatory diseases, all those have ocular symptoms, right? And they can as the diseases progress. So you want to know a lot more about your patient's past ocular history if they have any. Do they take any medications? Are they already on eye drops? So those are going to be really important questions to ask your patients. So get a really good and thorough history. Now, our good old-fashioned Snellen chart, you're probably very familiar with this, especially if you worked in pediatrics, you've seen different variations of this, but the Snellen chart is one way to measure central distance vision, right? In a pediatric setting, because our kiddos don't really know their letters yet, we do a lot of symbols and images, but a Snellen chart is something you'll come across in your primary care practice, whether you're treating adults, pediatric, across all ages, and it's something you want to get familiar with and understand what it means. So go ahead and put in that chat box. What do we consider normal vision? So I want to see your answers. What is normal vision? Awesome. See, I knew you guys knew this stuff. So 20/20 is considered normal vision. So what does that mean? So if a patient is standing 20 feet away from that Snellen chart, that they should be able to see, that is normal vision, right? It's expected. They should be able to see a certain line on that 20/20, right? So what is considered 20/40 vision? What does that mean? Is that better or worse? Go ahead and put that in the chat box. That's right. So that is worse vision, right? Because that means that a patient standing at 20 feet away sees what a person with normal vision sees at 40 feet away. So as that number gets bigger and bigger, it means their vision is worse, right? So what's considered legal blindness? Who knows that one? That one's a fun trick question. You might see this on the boards, you might see this in clinical practice, but what's considered considered legal blindness. I almost gave you the answer. Oh, good guess. Okay, so 20 and 200 is considered legal blindness. So that's just a little fun fact. But so for you have your Snellen chart, let's talk about some other vision testing. You also want to test for peripheral vision. So that's going to be the visual fields of confrontation exam. So you're going to have the patient cover one eye, you're going to cover your same eye, and you're going to bring your finger in and see and test their peripheral vision. And then you also can test for color blindness. Now, again, these are really basic exams. It depends on the specialty that you're in and when you would be using some of these tests, but I honestly, it's good to know about, but in practice, you're probably going to be sending them to their ophthalmologist to do routine eye exams to be really testing more in depth for that peripheral visual field, right? All right, so some red flags, some do's and don'ts. So boards want to know, are you going to be a safe provider? Do you know when to refer out? What is normal and what is abnormal? So I really want to flag these, and this is what you're going to keep in the back of your mind as you're sitting for your boards and as you're also seeing patients in that clinical setting. When a patient comes in, you want to be able to figure out, is this something that I can treat, or does this patient need to be seen right away by a specialist, by an ophthalmologist? So a sudden onset of vision changes or vision loss is not normal, right? We do have gradual visual changes due to aging, due to disease process, but sudden vision loss, sudden vision changes, that is not normal. So that should be a red flag in your mind. Also, eye pain. So patients might come in describing a little bit of eye discomfort, but if they have a lot of pain, they can't even open their eyes, they're really, it's not good. Should be a red flag for you. Photophobia is the same. So if they're having sensitivity to light, again, same thing. Some patients might say with their migraines, they have some ocular symptoms, but this is really like they cannot open their eyes. It's really sensitive to light. That is a red flag for you, right? If they have a headache with that vision loss, that's a red flag. Any recent trauma to the eye, that's a red flag. On your exam, when you're testing that visual acuity, if there's a decreased visual acuity that's sudden, that should be a red flag for you, right? So when I was first in practice, I would have all my eye complaints, do a Snellen visual acuity test and document it in my note just to document that it was normal visual acuity for them, right? Normal central vision, just to make sure that I didn't miss that red flag. You also want to check the pupils. So your perla, are the pupils equal, round, and reactive to light and accommodation? So if there's pupil irregularity or if there's a sluggish pupillary reaction to the light, those are all red flags, right? So know your red flags. The most important thing is know when to refer out and know when it's an emergent eye condition and situation. All right, quick quiz. So most common cause of vision loss in the older population, what do you think? Awesome. See, macular degeneration. You guys know it. That's right. So remember, this is a slow loss of central vision. So that is normal, right? And truthfully, what would we do for this patient? We definitely would refer them to ophthalmology and want to make sure they're getting their testing done because ophthalmology is going to be managing this patient. So our job in primary care is to make sure as our patients are coming in for their routine or even acute visits, we're making sure that they're routinely going in for their annual eye exam. Very good. Okay, so let's jump into some common eye conditions, ones that you're going to see a lot in primary care. First one is good old-fashioned conjunctivitis. So there are different types of conjunctivitis. The main three are bacterial, viral, and allergic. When you're first in practice, you could get a little tripped up by the bacterial and viral. They're kind of hard to distinguish when you're first in practice. I promise you, once you've practiced a lot, it'll be a lot easier. But go ahead and put in that chart, what are some things that are the same about bacterial and viral, and what are some of the things that are different about bacterial and viral conjunctivitis? Put that in the chart for me, the chat for me. Awesome. Yes. So bacterial conjunctivitis is what is that stereotypical pink eye, right? So you're going to have that patient come in and they're going to say, I'm waking up with a lot of crusting on my eyelid in the morning. There's a lot of drainage, a lot of pus. So you're going to get that purulent yellow drainage coming out. And the more they wipe, the more it keeps coming on, right? And then they might have some swollen eyelids, maybe some pain, maybe some itching, but it's really more that pus and that crusting in the morning. Starts on one side, it's highly contagious, so it does go to the other side. So that's bacterial. In viral, you're mostly going to see that it's more the discharge is not as purulent, right? It's more watery, it's more stringy. It also starts in one eye and moves to the other eye, also highly contagious, but they might have more of upper respiratory symptoms, right? You're going to see other viral symptoms. So cough, cold, sneezing, and they might describe that grittiness or burning sensation or irritation in the eye. So looking at the whole picture with the patient. In bacterial, it's really just the eye involvement, right? In viral, you're going to see some other viral symptoms. Sometimes it might trick you. So a patient might come in and the first sign of their viral infection is just that viral conjunctivitis. So you start treating them like bacterial, and then the other symptoms, the other start to present. So you kind of have to go with it and see, well, make your best judgment. Is this bacterial? If you have any doubts, go ahead and treat it, and then see how it progresses and just educate that patient on progression of that viral versus bacterial conjunctivitis. So what are some things that you're going to do? What's the treatment for bacterial versus viral conjunctivitis? Go ahead and put that in the chat for me. So how are you going to treat that bacterial conjunctivitis, and how are you going to treat that viral conjunctivitis? Yes, so bacterial conjunctivitis is going to need antibiotics, right? It will resolve on its own, but we do treat it with antibiotics because again, our goal is to make sure that we preserve the vision, right? Preserve the eye. And there is a slight chance that that could not happen, that you could have some eye issues, vision issues if you don't treat that bacterial infection. So we do want to treat it with antibiotics. My biggest recommendation for you is to avoid the drops in the kiddos because it's really hard to get eye drops in kids. They fight it a lot. So first line, what I like to prescribe is the ointment for the kids. And I always like to give the parents a refill on the ointment because chances are it's going to spread in the household. It's going to go to the other eye. It's going to go to siblings, maybe parents. So giving them a refill on that tube of antibiotics is going to be really important. Also, patient education is really important. So we've been talking about this. It's highly contagious, right? So talk to your patients about hand hygiene. Make sure they're washing hands after they're applying the ointment. They're washing pillowcases. They're not sharing towels. If they wear contact lenses, make sure they're not wearing their contact lenses while they have the infection. They may need to replace their contact lenses just to be safe, just so they don't keep reinfecting their eye. So patient education is going to go a long way in primary care with these viral and bacterial conjunctivitis. Now, allergic conjunctivitis. Tell me some of the symptoms of allergic conjunctivitis. How do you know it's allergic? I'm sure yes, both eyes. Awesome job, Andrea. So allergic conjunctivitis is going to be both eyes. So viral, bacterial, most likely unilateral. Allergic conjunctivitis, it's going to be bilateral. And you're going to see some other symptoms of allergies with that too. So it's going to be watery eyes, itchy, watery eyes. Maybe they have a runny nose. Maybe it's during their seasonal allergy season where it's really bad. They're going to also describe that grittiness feeling. So don't get nervous when they say, oh, it feels like something's in my eye. You're going to do your eye exam and make sure there's no foreign body, but most likely they're just feeling that grittiness of that conjunctiva, right? It's the irritation, the inflammation. So they're going to describe it as gritty, burning, irritated. So for these patients, what is the best course of treatment for allergic conjunctivitis? What do you guys think? I know you know this. What do you think? Yes, so you can treat them with oral antihistamines that can help. My favorite go-to is these patients are already taking oral antihistamines, so I like to give them topical eye drops that are antihistamines. Pataday is my go-to because that really helps give symptomatic relief, and also some cold compresses. Ideally, with any type of allergy, you want to avoid the allergen, but in this situation and in most situations, it's environmental, so it's hard to avoid. So you really want to give that patient some relief. So the eye drops, the antihistamine eye drops are really helpful. Those cool compresses are really helpful, especially if it's really itchy. That's going to help that patient a lot. Awesome job, you guys. All right, moving on to eyelid concerns. So with the eyelid, we have two different types that we're going to go over today. The one is the horgillum versus the chalazion. The horgillum is our typical stye. So you're going to have patients coming in and saying, oh my God, I just woke up and this thing came on. What is this? And their main concern is it something that I need antibiotics for, right? So with the horgillum, with the stye, you do not need antibiotics, and you need to educate your patients on that. It is going to be acute onset. It happens in the upper and lower lids. You can get internal versus external horgillums or styes. They are really swollen, really tender. Sometimes you're going to get that nodule is going to be emitting some pus, and you can see it in the whites of the eye. So that patient gets really concerned. They're like, what is this? Do I need antibiotics for it? And the biggest thing to do is make sure you examine, there's no signs of cellulitis, and educate the patient that they do not need antibiotics. It will resolve on its own. It should get better in 1 to 2 weeks. They just need to help it along by using those warm compresses to help reduce it, help it drain on its own. With chalazion, it's a little different. So it's more of a gradual onset. And so typically they'll see this develop over several months. It does also happen in the upper and lower eyelids. It's more common in the upper eyelids, but again, it will resolve on its own. So again, educating that patient, you don't need antibiotics, just warm compresses. And the other thing to educate in this patient is that if it's not improving, or if it's persisting more to 2 to 3 months, then they do need to go see a specialist to rule out any other issues and avoid complications. One of the complications is visual changes, because if that chalazion gets big enough where it's obstructing the vision, that's a concern. So they might need corticosteroid injections, surgical removal. So seeing that specialist to avoid potential complications is really important. But again, you don't need antibiotic ointment for either of these, and educating those patients on that is going to be really important. So don't prescribe those antibiotics if you don't need it. All right, so keratitis. This one's kind of a biggie. My main thing that I want to point out with keratitis for you, again, we're going back to our anatomy. So what is keratitis? It's inflammation and irritation of that cornea, right? And there's different types. There are a lot of different types of keratitis. And it depends on the layer of that cornea too, different causes. What I want to point out, what you're going to see on your boards is, again, those red flags, right? You don't need to know all the different types of keratitis and to diagnose all the different types. Again, your specialist, your ophthalmologist is going to do that. But what you need to know in primary care is how to identify those red flags and get them the proper medical attention that they need to avoid complications. And in keratitis, complications can include scarring, corneal ulcers, vision loss. So these are some pretty serious complications. So recognizing when it's keratitis is going to be really important, and getting them the medical attention they need promptly is also really important. So remember, a lot of these, let's look at the symptoms. A lot of them are red flags, right? So eye redness, that's pretty vague, but eye pain, photophobia, right? Blurred or decreased vision, that's not normal. And then this one, difficulty opening the eyelid due to pain and irritation. So that should be a huge red flag for you, right? That's not normal. And so, like I said, keratitis has a lot of different causes. It ranges anywhere from bacterial to viral to fungal to parasitic. So I really don't expect you to be able to diagnose all the different types of keratitis. It's really identifying that something's going on and they need prompt medical attention by the right specialist, right? That's going to be your job. And then also, please, please, please do not prescribe steroid drops, because if it is an infection that's bacterial, sometimes it can make those infections worse with the use of steroid drops. So don't make the situation worse. Make sure you're emergently getting your patient to that ophthalmologist so they can diagnose and treat it properly. One thing I want to talk about is you see how one of the causes wearing contact lenses too long. So with your contact lens wearers, what do we do in primary care? We make sure we educate those contact lens wearers to prevent any sort of complication like keratitis, right? So our job in primary care is to help educate and prevent diseases from occurring. So in your contact lens wearers, you want to make sure they discontinue wearing those contact lenses, whether or not that has come in contact with the cause of the keratitis. And then also make sure that they do clean their contacts properly. So proper cleaning of the contact lenses is important. And then one big thing is make sure they're not sleeping in their contact lenses, because that can cause a lot of complications, and you don't want that patient developing a corneal ulcer because they've been sleeping in their contact lenses. So educating their patients on that contact lens care is going to be important. All right, so this one is, I know you know it, it seems a little intimidating at first, but take a look at it. So patient comes in and they've got a rash on their face. It's near the eye. So we're talking about eyes, right? It's near the eye. Maybe the rash is a little bit on that lateral side of the nose. It's tingly, it's red, crusty, it's raised. What are we thinking in this situation? What could this be? Yes. See, I knew you guys knew it. So one of the things, one of the things I didn't say is it's along a dermatome. So on the exam, it will be very obvious. It'll say it's along a dermatome. It's a red, crusty rash on the face. It's tingly, and then you'll see very stereotypical rash for herpes zoster or shingles. So yes, this is an emergent referral out. So why is that? Remember, we talked about keratitis. What we worry about with herpes zoster on the face along a dermatome, especially on the lateral side of the nose, is that it could develop into herpes keratitis, which is an infection of the cornea caused by the herpes virus, right? So typically those do heal without any damage, but in severe cases, it can lead to scarring or blindness. Our job is to make sure that we prevent the blindness and the very severe complications. We preserve our patient's vision. So we're going to get them emergently over to the ophthalmologist. If you don't have an ophthalmologist that you can refer to be for the patient to be seen right away, they do have to go to the emergency room. So one of the biggest recommendations that I can make for you is make friends with people in your community. Have an ophthalmologist you can call and say, hey, I have this patient. Can you see them today? Because this patient does need to be seen within 24 hours. It's potentially life-threatening, potentially sight-threatening condition. So don't play around with this. Educate your patients on why they need to be seen right away and what you're trying to do to help them preserve their vision. Awesome. So glaucoma, we have two different kinds of glaucoma, two different forms. And basically glaucoma is a form of damage to the eye's optic nerve. So the optic nerve transmits information from the eye to the brain. And in glaucoma, there's some issue with the transmission, right? If it gets left untreated, it can get worse over time and it can lead to vision loss and blindness. So again, our main goal is to prevent those complications. It is the second leading cause of blindness in the world. So it is something you're going to see in the clinic. It's most common in the older population, but it can develop at any age. It's slow developing. And oftentimes, a lot of patients will not even know that they have glaucoma because they won't have any symptoms until it's gotten pretty advanced. So again, our job in primary care is to make sure that they're going to their routine exams and they're having their eye pressure checked, right? So what can you tell me about the difference between open angle and closed angle glaucoma? Who wants to put that in the chat? Who can tell me the difference? Which one is an emergency? Which one's not an emergency? So the two different types of glaucoma, you guys are absolutely right. It's two different types, right? In open angle glaucoma, it's more of that central vision loss, right? So you're getting cloudy vision, difficulty seeing when the light conditions change, some peripheral vision loss. In closed ankle glaucoma, it's more the iris is blocking the normal drainage of fluid in the eye. And so again, most patients don't have symptoms, but some can have an acute attack. So this is the one where we're going to see more emergent cases. So that patient's going to come in and say, hey, I have a headache, I've got some eye pain, I'm starting to see some halos around lights. You do your vision exam, they do have some vision loss, dilated pupils. So this is a medical emergency. So if you were to check their pressures, you would see very high eye pressure in the closed angle glaucoma, and that is a medical emergency. You need to get them over to the emergency room or an ophthalmologist right away, right? And so our treatment goals with glaucoma is you can't reverse the damage that's happened to the optic nerve, but our goal is to catch these patients early and start treatment to delay the progression, right? And all treatment types lower that eye pressure. So there's lasers, medication, surgery, but that's all going to be managed by your ophthalmologist. So getting these patients in for their eye exams and making sure we're catching things early is going to be our main job in primary care. Awesome. Okay, so what about this one? What happens if your patient comes in and their eye looks like this? They might also say they have been coughing or maybe even lifting something heavy. So what is this? If their eye's kind of pooling with blood, you see a lot of blood in that white of that eye. What do you think that is? That's right. It's subconjunctival hemorrhage. Good job, you guys. See, I knew you had this. So what do you tell your patients? So is there something that you should worry about or not worry about? What do you think? Is this serious? No. Okay, you guys are right. Yeah, it looks really bad, right? It looks really serious, but it's not. So reassuring your patients, making sure they understand that it's going to go away on its own. It's just going to take a little bit of time. It's going to be really helpful. It is really shocking to see when it first happens, but getting a really thorough history. So have they just been recovering from an upper respiratory infection? Did they just have a cold? Oftentimes that'll put a lot of pressure on the vasculature in the eye, so you can get this, but educating those patients and letting them know this will go away over time, especially with those kiddos asking mom and dad, did they just have a GI bug, a respiratory infection, maybe looking in their chart and saying, hey, my colleague just saw them last week, they did. So putting the whole picture together, asking those history questions is gonna be really important. Yes, and so Andrea makes a good point. So part of that history question is, are they on blood thinners? So this can happen pretty easily if they're on blood thinners, right? And so it's very scary when it happens to you, but reassuring that patient, so understanding that they're scared, they're worried something's bad with their eye, they're going to lose their eyesight, but reassuring them is going to go a long way. Awesome. All right, you guys, what about this? What could this be? So what if a patient said they had sudden painless loss of vision, right? So that's going to be the key teller there. It's painless, sudden vision loss. They might see some floaters, some flashes of light, and then they'll probably give you a picture like this on the boards. So what's happening here? What do you think? So if you said retinal tear or retinal detachment, that's absolutely right. So good job. So that big telltale sign that they're going to tell you is it's painless. All of a sudden they had some vision loss. Maybe they feel like a curtain's coming down. So that should make you suspect that something's happening with their retina. It's either tearing or it's already detached. So this is an urgent referral to an ophthalmologist. Again, they need to be seen within 24 hours. Very good. So key takeaways for the eyes: know your red flags, know when to refer. So that's going to be really important, and prevention, prevention, prevention. So make sure your patients are going in for those routine eye exams, and they're also caring for their eyes, especially if they're wearing contact lenses. Educating those patients to help prevent those complications is going to be really important. Awesome. So let's go to the ears. Again, anatomy is going to be really important with the ears because once you know normal, you'll be able to recognize abnormal when you see it in the clinic. So knowing the inner ear anatomy, the canal, the external ear is going to be really important. You have different types of hearing tests that you can use in your outpatient clinical setting. The Rhine test, you're going to see this on the board. So you're going to need to know the difference between Rhine and Weber. So what is the Rhine test testing for? It's that conductive hearing loss. So knowing between the air conduction and the bone conduction, what's normal, what's abnormal, that's going to be really helpful to you. So go back and review that. Also, the Weber test is going to test for conduction as well. So this is the technique of the Rhine, and this is the Weber. So both test for hearing loss. And so go back and review those so you're ready for your boards. Okay, let's jump into some common ear conditions. So here, what would we suspect if we saw, if the patient came in and said, I have ear pain, it's unilateral, maybe some fullness or hearing loss in that ear. They could have a fever, they have other symptoms, maybe they have sinus pressure, but it's mostly that ear and it's really bad, it's painful. You take a look with your otoscope and you see that tympanic membrane is red, it's bulging, you see a lot of pus behind that tympanic membrane. What do you guys think this is? So go ahead, shout it out. Yes, otitis media. So acute otitis media. Awesome. So how do we know this is acute otitis media? Remember, we have that tympanic membrane. It's going to be bulging, and that's what they're going to say on the boards too, right? That tympanic membrane is bulging. It's red. And then you're going to see that opaque or erythematous tympanic membrane. You see all that pus behind it. So how do we know it's not otitis media with effusion? Go ahead, shout it out. Yes. So again, you're not going to get that bulging with otitis media with effusion, right? You're not going to get that bulging. You might see some yellow or clear fluid behind that tympanic membrane, but it's not going to be bulging at you. So take a look at pictures between a normal tympanic membrane, a bulging tympanic membrane, and you'll see the difference. And why is it important? It's important because the treatment for acute otitis media is very different from otitis media with effusion, and it gets misdiagnosed a lot, and people start patients on antibiotics that they don't need. So make sure you understand the difference so that you can help educate your patient and also get them the right treatment so they're having symptom relief, right? So in that acute otitis media, yes, you do want to start oral antibiotics, but in otitis media with effusion, we treat it more symptomatically. So we're going to try to help with some nasal steroids, making sure we relieve some of that pressure and that fluid and that drainage in that ear so that they actually get some symptom relief, right? Very good. So who can tell me what's the first line treatment for acute otitis media? Go ahead, put it in the chat. I know you know it. That's right. So Augmentin is going to be your first line. So you just want to make sure that you're using an antibacterial drug that's going to cover for all those potential pathogens, right? And so most common pathogens for acute otitis media is S. pneumoniae, H. influenza, and M. catarrhalis. So making sure you're covering all those is going to be really important so that patient has some relief. And then in acute otitis media, what if it persists and recurs? Then you want to get them over to ENT to figure out what's going on. So in acute otitis media, it can persist for up to 12 weeks, but if it's beyond that, then you want to get them over to ENT. Okay, so what if the pain instead in the outer ear? So the patient feels like, oh, when I move that outer ear, when I move that pinna, I can really feel it's really irritated and really painful. When you look in the ear, you might see a lot of swelling, might see a lot of debris. That tympanic membrane looks normal. So what are you thinking in this? What could this be? Otitis externa. Awesome job. So the main thing to know about otitis externa is that debridement is going to go a long way in helping heal that ear, right? And it's more of an infection of that ear canal. So debridement is going to really help with the healing. If you cannot view the tympanic membrane, if you can't visualize it, or if it's ruptured, do not put those eardrops in. Get them over to ENT because they can do it much more safely and make sure that they're not damaging those structures of the inner ear. But basically, you want to decipher between external and external otitis media, also commonly known as swimmer's ear, and get them over to ENT if that tympanic membrane has ruptured or if you can't visualize it. You're going to start that patient on antibiotic drops if it's mild to moderate and you can visualize that tympanic membrane and it looks normal. And basically, if they're not improving after 7 days, or if it's not completely resolved after 2 weeks, then you're going to get them over to ENT too, because they need to then culture it. All right, so let's talk about this patient, a 58-year-old male of Asian descent. So that's going to be important whenever they give you a demographic like that, pay attention. It's a 58-year-old male of Asian descent who comes in saying he has left-sided hearing loss, vertigo for the last 3 to 4 years. What might be something you're suspicious of? So left-sided hearing loss, vertigo, 50-something-year-old Asian male. So this one's kind of tricky. Could be an acoustic neuroma. And so the reason for that is because acoustic neuromas are most common in the Asian population between ages 50 to 60. And so for these patients, what do? We need to get them over to neurology to do a more thorough evaluation and see if it's caused by a tumor of the acoustic nerve. So this is definitely something we're going to get over to the specialist. But for your boards, pay attention to those demographics. That's what this question is highlighting. So when they tell you something like Asian descent, they give you the age, you want to see what's going to be the most common finding in that population. So vertigo is a very big topic. For today's purposes, we're going to just briefly go over peripheral vertigo versus central vertigo. So what is vertigo? Your patients are going to come in and going to say, I feel like the room is spinning. I feel like I'm floating. So vertigo is a sudden internal and external spinning sensation, and it's often triggered by moving your head too quickly. There are different types of vertigo, like we talked about. There's peripheral and central vertigo. Peripheral refers to disorders involving disturbances in the inner ear. So again, knowing the structures of the inner ear, you'll likely not be diagnosing anything more than benign paroxysmal positional vertigo. We'll talk a little bit about that, but it could be something like vestibular neuritis, labyrinthitis, Meniere's disease. But knowing the structures of the inner ear will help you with your diagnosis, will help you determine if it's something you can do an outpatient or if you need to get them over to a specialist for a more thorough evaluation. Okay, so benign paroxysmal positional vertigo, that's the one you're probably going to be diagnosing and managing an outpatient. How do we know what's a maneuver we can use to diagnose BPPV? Yes, so Dix-Hallpike, do you guys remember that? So Dix-Hallpike maneuver will help us identify whether this is, in fact, benign paroxysmal positional vertigo. The patient's going to come in and say, the vertigo comes on suddenly, the spinning comes on suddenly. When you ask your history questions, ask if it happens with head movement, how long does it last? So with BPPV, it should last only a few seconds. That's also going to be a telltale hallmark sign. So it comes on suddenly, lasts only a few seconds. It's triggered by head movement. You do your Dix-Hallpike maneuver and it's positive. Whichever side it's positive on, it's that ear involvement. So making sure you understand what's happening with that ear, it will help you with the treatment. So oftentimes with BPV, you just need to, vestibular rehab is going to be the treatment. So either have the patient do the exercise at home or refer them to physical therapy. What I personally like to do is I explain to the patient what's going on. I give them the exercises for at home, but I do tell them that the exercises do trigger the vertigo, and oftentimes patients really don't like that. So I'll refer them to physical therapy and tell them, even if you go for a few sessions just to get the hang of the exercises, and then you can continue to do them at home, it's going to be worth your while. And over time, it will get better, but they do need to do the exercises to help it along. And the Epley maneuver is going to be one of those helpful exercises that they're going to do, both in physical therapy and at home. So printing out the exercises for them is going to be really helpful. In central vertigo, it's definitely more serious. So if you're suspecting central vertigo, it can have more serious causes like things like brain trauma or stroke. It's typically originating in the brainstem and the cerebellum. So this is definitely something you're not going to be managing. You want to get them over to the specialist. But deciphering between peripheral and central is going to be helpful in your exam. Awesome. So let's jump to the nose and throat. So rhinitis, good old-fashioned rhinitis. How do we treat this? Go ahead, put it in your chat. What do you think? A patient comes in and they say, my nose is running. What are you thinking? How are you going to treat this? Well, there are different types of rhinitis, so you guys are absolutely right. So there's allergic rhinitis. It can also be caused by an upper respiratory infection. So you have to figure out, why is that nose dripping, right? So in most cases, it's going to be allergic rhinitis. It's environmental. So helping educate that patient is going to be really helpful. What I like to do is make sure patients understand that removing those allergens is going to really help with their nasal congestion. So getting them a good nasal wash is going to be really important, and telling them they can do it morning, night, and then followed up with a nasal spray like Flonase just to help reduce that inflammation is going to be helpful. Oftentimes patients are going to try over-the-counter decongestants. Just make sure that you're educating them on not using them long-term for avoiding side effects, right? Because you don't want them developing rebound congestion. And then just telling them that they can also, if it's seasonal, try an oral antihistamine, see if that helps. But what I found to be the most helpful is tackling that nose directly with that nasal saline wash and some Flonase with that nasal corticosteroid, because that really does help with the inflammation. So do the nasal wash first just to wash out those allergens, and then leave the medicine behind, then follow it up with the Flonase just to help reduce the inflammation, and that really does help improve some of those symptoms. All right, so what if that patient comes in with a history of, I've been having this, I had this upper respiratory infection, I had a lot of nasal congestion, it seemed to be going better, but then now I have a lot of pressure in my face, it's feeling really tender on one side, I can't seem to blow my nose anymore, maybe they might have some purulent discharge, but it's mostly going to be they're really stuffed up, they can't even blow the nose, they're having pressure on that side, maybe they have some tooth pain. What do you guys think this is? Yes, see, I knew it. You guys know it. You guys are all ready. So this is bacterial rhinosinusitis. And how do we treat this? What's our first line treatment? This requires antibiotics for sure. So first line treatment can be augmentin. I also, depending on the severity of the bacterial rhinosinusitis, will sometimes start the patient with that amoxicillin. You can kind of gauge, but the guidelines do say to give them an augmentin. Augmentin does have a lot of side effects. So educate your patient on that. If they develop that yeast infection, make sure you're treating that. If they do develop, make sure they're having probiotics with their antibiotics, they're taking it with food. So a lot of patient education when you're prescribing that augmentin, but absolutely this sinusitis needs antibiotics. So it's just going to get worse, and it's been going on for a long time. So help your patient get some relief. All right, so here's a picture of a nosebleed. So what are we talking about with nosebleeds? Why do we need to talk about it at all? So with nosebleeds, just remember there are two different types. You're going to see them really commonly ages 2 to 10 with your kiddos, and just helping reassure and educate the parents on what they need to do. So applying pressure, put some ice on it, lean forward. You don't want them leaning back because they don't want to be swallowing that blood. And then making sure that you're catching those posterior nosebleeds, because those can be really dangerous, may indicate a sign of hemorrhage depending on, again, the anatomy. So with the posterior, we worry about the arteries. So making sure you're asking your patients if they're over the age of 40, if they're on anticoagulants, they're having this nosebleed that won't stop, they do need to go to the emergency room because they need to make sure that they're not going to have significant blood loss, and they'll probably need some packing. So that's what you need to know about nosebleeds. Deviate septum, just a quick shout out about deviate septums. Take a look at your patient when you're doing your exam. If they do have a deviate deviated septum, sometimes they're going to have a lot more nasal congestion. They might be more susceptible to the bacterial rhinosinusitis because they're not getting the outflow as well from their sinuses. And then they might have some sleep issues. So asking the questions is going to be really important in helping you manage those patients. So deviated septums are pretty common in the outpatient world. So mouth conditions. So your patient comes in and this is what their tongue looks like. What do you think that is? It looks pretty scary, right? So what do you think that is? It's asymptomatic. It's maybe patient has mild discomfort, but you see these patterns on their tongue. So that's called the geographic tongue, and it's actually benign, but something patients will come in with, or you might find just coincidentally on your exam. It can be associated with psoriasis or reactive arthritis, but reassuring the patient that that's benign and nothing to worry about. But looking at the overall picture, so if they're having some of those other skin conditions or joint problems, they might need to see a rheumatologist to figure out if there's something else autoimmune going on. What if your tongue comes in and what if the patient comes in and they've got white patches that don't wipe off? So white patches along those lateral side. What do you think that is? Yes, good job. So it's leukoplakia, right? Which is a precancerous. It can be a sign of oral cancer. So you definitely want to get this patient over to a dentist for further evaluation and management. And then what about if those patches did wipe off? And then you also have a history, maybe that patient recently was prescribed inhaled corticosteroids. What are we thinking then with that patient? That's right. So that in that patient, you should be thinking about oral thrush, right? And we definitely want to make sure we treat that or before it gets worse. And we'll treat that with nystatin, swish and spit typically. And then what about this last picture? What happens to this patient when it comes in with describing painful round oral lesions like this? What is that most likely? Awesome job. That's right. So it can be canker sores, right? And those will go away on their own, but sometimes we might need to help them along, putting a little topical lidocaine on it, but also educating the patient that it's totally normal, but sometimes it can be really painful, really uncomfortable. So helping those patients is going to be important. Good job. All right. So what do we think this is? So a patient comes in, they describe these painful fissures in the corners of their mouth. What do we think that's called? Yeah, this one's a tricky one. So that's called angular chelosis. I don't really know how to pronounce it myself, but it's something that you're not going to see that often, but it is something that does cause the sides of the lips to get cracked and fissures to form. You might see it in a patient that drools at night, so telling them to put a little Vaseline there to help prevent it's going to be really helpful, but it can also be caused by yeast or a vitamin B12 deficiency, so we do want to do a little bit more digging to figure out the root cause of that, right? Awesome job. Okay, so you have a patient coming in, they complain of dry mouth, dry eyes, and it's been happening over the last 3 months. What do we think this could be? It's a young female patient, maybe in her early 30s, so the demographic is going to be important. And that dry eye, dry mouth, what do we think that is? So you're absolutely right. So we're thinking Sjogren's syndrome, right? And remember, in this patient, you definitely want to evaluate to make sure the other autoimmune disease that it's related to aren't what we're looking at. So it's related to lupus and rheumatoid arthritis. So you want to make sure that that patient doesn't have any other symptoms of those diseases. And then if it's just the Sjogren's syndrome, it can be just uncomfortable. So making sure they're getting frequent eye exams, frequent dental exams. They're more susceptible to dental cavities and caries because the flora in their mouth is off because they're not producing as much saliva. So helping them, educate them on foods to avoid and things they can do to help with that saliva production is going to be really important. Their mouthwashes, toothpaste they can use. They can also use sour candies to help with that saliva production, and making sure they're going to their routine dental exams and their eye exams is going to be helpful. So strep throat, this is, pretty obvious and it's going to be on your board. So knowing how to diagnose and treat strep throat is going to be important. So what is the first line treatment of strep throat? What do you guys think? Yes. So penicillin, you're absolutely right. You're going to start this patient on penicillin. And why do we treat strep throat? What do you remember? So what's a potential complication? That's right. So rheumatic fever, right, which can impact the heart, cause mitral valve issues down the line. So we definitely want to identify and treat the strep throat with the antibiotics. So you're going to see those telltale signs. A patient's going to come in, their throat's really sore. They're going to have that petechiae in their upper palate. You're probably going to do a rapid strep. It's going to be positive. So you're going to start that patient on antibiotic treatment. Awesome. So what if the patient says, my throat is really sore? I can't, swallowing is a little difficult. On the exam, they might describe it as a hot potato voice because they can't really close their mouth or get the words out well. What are we thinking in this scenario? You're looking at the exam and you see that uvula is deviated. You see one side, those tonsils, you see maybe it's swollen just one side, but it's not, it's looking unilateral. What are we thinking this could be? So for sure, this could be a peritonsillar abscess, which is really concerning because that can obstruct the airway, right? So this is an emergency. So we need to get them over the emergency room and make sure that they're draining that abscess. Good job. So on the exam, you're going to see it as a hot potato voice. And then what about in mono? So how is that patient going to present for mono? So they might come in with a severe sore throat. They might be really fatigued. It's come on gradually, but they can't seem to do their normal activity. They're getting that nocturnal fever. You're going to see some cervical lymphadenopathy on exam, low appetite, some weight loss. What do we think? What are we thinking then? That's right. We're thinking this could be mono, right? And so in mono, what causes mono? What's the virus that causes mono? So the most common cause is the Epstein-Barr virus. And remember, this is a virus. So in strep throat, it's bacterial, and mono, it's viral. So do we treat it with antibiotics? Absolutely not. And if we do, what happens? We can actually accidentally cause a rash. So with mono, we just want to treat them symptomatically and educate that patient on what are some concerning signs. So to diagnose them, you can get some blood work. You're probably going to get the history and exam, and you can either do a mono spot or confirm it with the antibody testing. Monospot has, it's not as sensitive as we would like. You can get a lot of false negatives. So the antibody testing is helpful in that patient where you're getting those negative monospots, but you really suspect this could be mono. You might want to get the antibody testing done. And then also, what organs are we watchful of in mono? So what are we worried about with this patient? That's right. So some potential complications could be splenic rupture or airway obstruction. So we definitely want to make sure we do our GI exam and then counsel that patient to make sure they're not doing it. They're avoiding contact sports for at least 4 to 6 weeks. Usually they'll recover from the mono in 2 to 4 weeks. So making sure they understand that they need to be avoiding those contact sports for at least 4 to 6 weeks is important. And then specifically on your labs, you're going to see an elevated atypical lymphocyte. So you're going to see that on the exam. So knowing you're probably going to see elevated LFTs, looking at liver function, that atypical lymphocytes is going to be another telltale sign that this is mono. And then patient education. So what do you want to tell your patients about this? So what should they avoid aside from the contact sports? So that's right. So it spreads through the saliva. So that's why it's called, the kissing disease. So they shouldn't be sharing food, drinks. Sexual activity also can be, it could be passed along through semen as well. So you just want to make sure you're educating your patients to help prevent the spread of mono to others. It's going to be really important. All right, you guys made it through. You did an awesome job. I told you, you knew all this. You're going to do great on your boards and you're going to be a safe provider. Let's just do a couple of practice questions before we wrap up for the day. So retinal detachment, it requires an urgent referral. Permanent and severe vision loss can occur if it's left untreated. So we talked about that, right? So healthcare providers must recognize and act. So this is an emergent referral if you're suspecting retinal tear or retinal detachment. Knowledge of which risk factors are crucial. So what factor placed the patient at risk for retinal detachment? And select all that apply. So is it young age? Is it myopia, cataract surgery, family history? Remember, you're asking all those history questions, right? To get a full picture. So if you said B, C, and D, you're right. So family history is really important. If they've had any cataract surgery, remember you're going to ask about those prior procedures done, and myopia. All those put the patient at increased risk for retinal detachment. Young age is actually not an increased risk. Older age is an increased risk for retinal detachment. So knowing the demographics is going to be really helpful for the boards. They're going to throw really obvious things at you. All right, last practice question. A practitioner wants to assess the patient's hearing after reports that the patient feels they are constantly asking people to repeat themselves, so they're having some hearing loss. The practitioner strikes a tuning fork, so remember your technique, and places it at the base of the mastoid bone just behind the ear, so bone conduction, right? And asks the patient to tell the practitioner when they no longer hear the sounds of the tuning fork. The practitioner then places the tuning fork next to the ear and asks the patient if they can hear any sound, so air conduction. What does this test assess for? Is it A, conductive hearing loss, B, sensorineural hearing loss, C, mixed hearing loss, or functional hearing loss? Go ahead and put that answer in the chat. Yes, you're right. So it's conductive hearing loss, and that's going to be your Rhine test. So going over those tests is going to be really important, the technique for your board. So practice, practice, practice. All right, you guys, you did an awesome job. I'm going to let you put your questions in that little chat box as we wrap up here today. I'm going to remind you that you can go to our website and check out our question bank. We have almost 1,500 questions available for you. We put out new questions every week to get you ready for the boards. You're going to do an awesome job. We have a 3-day live review coming up at the end of the month. Registration's already open, so join us for that. You're going to feel really ready and prepped for the boards if you join us for that comprehensive 3-day live review. Follow us on social media. You can scan this QR code so you can register for all our webinars coming up. We've got a lot of great stuff for you guys in April. Every week, we've got at least 2 to 3 webinars covering everything from dermatology to neurology. So definitely go ahead and make sure you sign up for these live free webinars. And as always, feel free to email us directly. We are here for you. You're going to do an awesome job. You're going to do really well on your boards, and you're going to be a really good and safe practitioner that practices evidence-based medicine. I know you can do it. We're here for you. You're doing an awesome job. All right, you guys, that's our time today. So again, email us directly if you have any questions. We hope to see you at our next webinar, and we hope to see you at our 3-day live review.